Hello and welcome to the Monday morning message for Chapter 13, Billing and Collections. Now, this is one of my favorite chapters, and part of the reason for that is that I've really come to like and try to understand better the business side of the business of healthcare. We'll discuss some of the main topics about billing and the collections process when you're trying to collect payments from patients, in particular things like co-pays and co-insurance and deductibles, and how we go about doing that. So the way most health plans, private insurance plans, are designed as far as the fee schedule is concerned is that Medicare sets up the fee schedule that most private health insurance follows. So the way I typically say to people is that anything that Medicare does, private health insurance is likely to follow that path. So an example might be if there's a new medication on the market or a new immunization on the market. Usually until Medicare actually covers paying for that or reimbursing for that, private health insurance won't reimburse for it either. So once Medicare starts to reimburse, then private health insurance will follow suit. Now, Medicare sets up a fee schedule, and that fee schedule that Medicare sets up basically becomes the highest level of fees that a doctor's office can charge for services. So part of how they do that, and there's a fairly what I think is a fairly complex mathematical formula for figuring this stuff out. But one of the first things that they do is they'll apply a GPCI. Okay, so the GPCI is the Graphical Practice Cost Index. Okay, now that what that does is basically it looks at kind of an average of all of the cost of a particular procedure or service all across the country, and kind of comes up with an average price for what's typically charged for that. And then there are factors that are geographically related that go into it. So there's a national conversion factor that's used in order to determine, how much something is in one place versus another. So for instance, things typically can be charged at a higher rate in a more urban center like Los Angeles or San Diego. A two-view chest x-ray in those two places might run somewhere in the neighborhood of $200, but in an outlying rural area like Hemet or Calexico, that may be $120 or $130 for that same procedure, but that's based on geographic location. Okay, so that is done through that national conversion factor that every year Medicare puts together a conversion factor number, and that helps practices determine where they should be charging their services. Now, that conversion factor fits into the formula that also has what's called the RVU, which is the relative value unit. Now, that relative value unit has basically three components in there that we look at when we are determining what fees to charge. Okay, so the three determining factors in the RVU are what service is being performed, the type of expertise that the physician has in that service, and then what their malpractice insurance cost will be, so we can roll that into part of the fee. Now, to let you guys know, malpractice insurance in the United States typically costs on average a physician between $14,000 and $16,000 a year for malpractice insurance, and that's per provider. So if you have 4 providers in a practice, then you have to take that 14,000 times 4, and that's about $56,000 a year that 4 provider practice is going to pay just for malpractice insurance. So part of that malpractice insurance cost gets rolled into the relative value unit. Now, the participating provider, that would be a physician or a physician's office that agrees to take a certain insurance. Okay, so that could be private insurance, United Healthcare, Cigna, Aetna. That could also be Medicare or Medicaid. or Medi-Cal in the state of California, which is the state's Medicaid option. So once you agree to be a participating provider, what you're agreeing to is to contract with that insurance to accept that insurance's fee payment schedule, which means that if you perform a procedure with United Healthcare and they pay $100 for that procedure maximum, then you're agreeing that that's all you're going to be able to get. So you're going to charge the $100. Now that might be different with Aetna. Maybe Aetna only pays $90 for that same procedure. Once you have agreed and you're contractually obligated to that. So that's part of being a participating provider. And again, most insurance companies, they will create their fee payment plans based on Medicare and what Medicare pays, what their top payments are for things. That's where those private health insurance companies are going to set their fee schedules, really right in alignment with Medicare. Now, when we get into things like, what is the patient supposed to pay? So, most patients that have some form of a managed care plan, like, United Healthcare, Cigna, Aetna, as a private insurance, they've agreed as a patient, you have also agreed as a patient that you have signed a contract with that insurance company to accept the terms of the insurance contract. Now, that contract may indicate or dictate that you pay copays for visits, right? So maybe your standard office visit with your, personal care physician is, $20 for that copay. Well, you've agreed to pay that $20 at the time of service as somebody who contracted with that insurance. So that kind of sets up understanding the misconception that a lot of patients have that somehow the offices determine the copay amounts, and that's simply not true. It's your insurance company that dictates what the copays are, and that is a contract between you as the patient and your insurance company. Our job as the provider is to understand that contract and follow the rules of the contract, which is to collect that $20 copay every time you come in for a visit. Same thing with certain deductibles we'll collect as well. Co-insurance might be collected at the same time. So that's a contractual obligation we have by accepting that insurance company, is that we will in turn collect any fees that need to be collected per your insurance contract. Okay, so what's a good way to ensure that patients pay? This form that was in the PowerPoint is kind of an interesting form, because it talks about a patient who maybe ends up with having a big bill. And we all understand that, healthcare is expensive, and sometimes patients will accrue bills with us. And that's okay. Most doctors' offices, that's okay. We understand that it's expensive. We understand that everybody can't pay for things, all at one time. So let's say somebody racks up, like in this example, an $800 balance. Okay. Now the doctor's office may decide to draw up a little agreement with that patient. Putting things in writing is always the best thing to do. Documenting everything keeps you out of trouble, right? So this one says that whoever, John Smith, agrees to pay Monroe Family Practice $100 every 2 weeks until my $800 balance is paid in full. I understand that finance charges will not accrue while I'm making these payments, but if I stop making these payments on my balance, that finance charges will begin to accrue. Doctors' offices can put finance charges or interest on payments. In particular, it has to be that the patient is going to need more than 4 payments. So if there's more than 4 payments involved, then we can assess finance charges, and that is through the Truth in Lending Act. Part of that was we have to put that on paper for patients. So honestly, most practices don't do this. Most practices that I've worked for in my career, usually we'll do verbal contracts with patients. We'll document them in the chart that we made these arrangements, but oftentimes depending, and it depends on the practice, so it's typically situational. But a family practice like what I've worked in most of my career, we get to know patients fairly well. So when we know that they're having a financial hardship, we'll typically work out a deal with them to pay back whatever, because basically what the doctor's office has done is given you credit. If you amount a bill, like in this situation, $800, we've given you $800 worth of credit, right? So then you need to pay that back. And when you extend credit, you can apply finance charges. In this situation, it has to be if the patient's going to make more than 4 payments to pay this off. We can do that. It just creates a lot of paperwork for most offices. So the majority of us don't charge finance charges, and a lot of us won't do necessarily, this type of a form. We'll do a verbal contract with them, but we will hold patients accountable to maintain whatever they said they were going to do. And again, we'll document in their chart that we are doing this payment plan with them. Okay, so that's important stuff. When is the best time to talk about things like finances with patients? The best time typically is to do it up front. Usually the first time they ever come to the office, we'll talk about things like no-show fees, the policies on things like collecting the copay at the time of service. And oftentimes we have to remind patients of these things. Okay, so usually we try to remind them when these things come up, or if we're anticipating that these things might come up. Now, when we talk about things like collections, it's important to understand or to know your state's statute of limitations on collecting on debts. On page 267 of your textbook, there's actually a fairly good example. I think it's fairly up to date, but I wouldn't quote on this, so I would always look this up per state. But the statute of limitations for collecting on these debts varies from state to state. Okay, so when you look at that table on page 267, it kind of talks like California's 4 years. So you have 4 years to collect on those debts. Other states are 6 years. Some states, Illinois, Indiana, Iowa, 10 years to collect on debts. I think the lowest year amount, Maryland is at 3. Delaware, Washington, D.C., and North Carolina are all at 3 years. So this can vary. Probably the goal for most of us is to collect as quickly as possible, right? We want to do that as fast as we can. But again, we understand that patients can have difficulty paying. We want to work with patients to get those things done. We want to work with them so we're not creating more hardship for them, but we also want to collect on money for services that we've already given them. So there's kind of that balance that we need to have, okay? When we do try to do collections with patients, some of the important things to remember is to speak to patients while they're in the office. Usually face-to-face is better than speaking to patients on the phone. However, we do a fair amount of collection on the phone as well. Speaking to them in a private place, trying not to violate HIPAA. So speaking to patients about outstanding bills at the front desk, maybe the reception area where it might be a very busy reception area, not a good idea. So most of us will either pull patients back to exam rooms, or we'll pull them back to a private office or a conference room to discuss some of these sensitive issues. Okay. And you've got to remember, it's always a sensitive issue whenever you're talking to people about money, right? So remembering that, having empathy with patients, understanding that this is difficult sometimes for patients is important to remember, okay? So face-to-face is typically the best way to do it. But be considerate and be kind with patients, and understand that they may be going through some troubles that we need to try to be mindful of. Okay, forgiving deductibles and co-payments, that's a no-no. That's considered insurance fraud. We can't do that. We still need to collect. Again, this was a contract that the patient agreed to when they agreed to accept their insurance, that they would agree to abide by the rules, which says, hey, if there's a copay applied, they've got to pay the copay. So typically we do not write those things off. We can't do that. So that's usually a no-no. Types of payments received in the office: cash, debit card, credit cards are pretty standard. For those of you that don't use or aren't old enough to know what a personal check is, the majority of offices will still take personal checks as well, and that's another good form of payment. But cash and debit or credit is typically the way we accept most payments. We run into issues, right, with personal checks because personal checks could bounce. They may not be good. The patient may not have funds in their accounts to cover those checks. So that can become an issue, which we don't really want to have for us or for the patient. Okay. Let's see. Professional courtesies. That one you don't see very often, and it's usually kind of a behind the scenes kind of thing. Good example, I'll give you a good real life example of it is one time many years ago I worked in a family practice, and we sent a lot of patients to a dermatologist. And that particular dermatologist, there was an issue that I was having, so I said, maybe I should go and see a specialist. So I got a referral from my office because my provider actually worked in the office I worked in, which is a nice benefit of working in this profession. Is some practices will do that; they'll see their employees as patients. So I went to the dermatologist, and when I went back to the front desk, the doctor had told the front desk not to charge me for the visit, and I was fully prepared to pay for the visit, but he was extending what's called a professional courtesy, and that was his way of thanking. Even though I'm not a doctor, my office that I worked in, we sent him a lot of business. We sent a lot of patients to him. And that was his way of thanking us, take care of us, didn't charge me for that visit. And I only saw him one time, so it wasn't a big deal. I'm sure if I'd have had to see him many times, he probably wouldn't have extended that courtesy on every single visit. But the first one was extended as a professional courtesy, as a way to say thank you for your office sending me as much business as you send to me. Okay, so again, it's a nice benefit of working in this profession. Sometimes, if you're able to get a professional courtesy like that, that can be a benefit of working, just like getting health care or dental insurance or having a 401k. It may be another benefit that you accrue by working in this. Okay. Let's see, what else can we cover on this one? Collecting from patients, we talked about that. Do it in private, best way to do that. Payment arrangements should include a commitment from the patient. So again, getting it in writing, or at least documenting what we're going to do with the patient, is important. Dismissing a patient for non-payment. This does happen. We try not to do this very often. Again, we understand that healthcare is expensive. We understand that patients aren't always in a position to pay their full amount. So usually if we dismiss a patient from the practice, it's typically because we had an arrangement and the patient hasn't followed through on the arrangement. Usually the patient is well more than 30 days past care or past a due date for a payment, and they are no longer responding to any of our queries. So any of our phone calls, mailings, they're not responding to any of that anymore. Then usually what we'll do is we will send a certified letter to them, explaining that we're giving them typically 30 days of care, and after that they need to find a new physician. So that leads us into how do we try to collect on those patients that we might have dismissed. Well, obviously we want to continue to try to make contact with them, but that may require us to, at that point, maybe use a collections agency. Now, this usually doesn't happen unless the patient owes a lot of money. So we have to weigh the difference between what they owe and how much it's going to cost us to use an outside company to chase after that. Okay, so if a patient only owes us $100 or $200, most of the time we will continue to try to collect that ourselves. We will continue to send letters. We'll continue to try to contact them, and eventually maybe we just write it off as a loss, write it off as a business loss. If a patient owes us much more than that, say $1,000, $2,000, $3,000, then we might consider the use of a collection agency. Because typically when you use an outside agency, you're going to pay them a percentage of whatever is collectible. So for instance, if we were trying to collect $3,000 and using that collections agency, we have to pay them 10%, we would have to give them $300 from that $3,000. That's where we have to weigh. Is it worth using a collection agency, or is it better to just write off the loss? So think about it. 10% is fairly low. So think about it. If we were doing 20% of $3,000, that would be $600 we'd have to pay that collections agency. So then we would get $2,400 of the $3,000 that was owed to us. Is that worth it? Is it worth losing the $600? Maybe, maybe not. Okay, but that's typically what has to be taken into consideration when we use a collection agency. So we try not to use them very often if we can avoid it. Okay, and then if we can't get anything, then see accounts are written off. We'll just write off the loss. Okay, on deceased patients, there's a couple of things that we might do for deceased patients. Again, we may just write off what they might owe us. Usually we don't allow patients to amass a lot of debt. We try not to do that. So if somebody dies and they owe us, $500 or $600, a lot of times we'll just write that off as a loss. However, if a patient does have an estate, meaning that they have some, they have an executor of their estate who maybe they had property, maybe they had certain valuables, collectibles, that type of stuff that the executor of the estate was going to possibly sell those items, get the money, and then pay off certain debts with that. We might want to get involved in that, which means that we have to petition in probate court to receive some of the funds from an estate sale. Now, that takes time. It takes time to do stuff like that, so we may or may not get involved in doing something like that. Again, it probably depends on how much the patient actually owes us. Okay. The other thing that we might do too would be small claims court. Typically, I believe in the state of California, we can take somebody to small claims court for up to $5,000. So that would be us filing a claim in small claims court without an attorney. Okay, and that's what small claims court is. It's being able to civilly sue people without the use of an attorney. You oftentimes see that with things like people that owe back rent, that skip out on a landlord for rent. Usually that is a small claims court issue because most landlords won't usually let you skip out on rent. It's more than $5,000. So you might be taken to small claims court. Again, that takes time. Somebody's got to go represent the office to do that. And we're probably not going to allow bills to get that high that we're going to have to take that type of a measure. Okay, so I kind of skipped a little bit there. Bankruptcies, two different types of bankruptcies, and patients file bankruptcy fairly frequently. So we do get notification if we were listed as a creditor on a bankruptcy. And two different types of bankruptcies. Chapter 7, which is a total liquidation of your debt, which means if the court agrees, then they say all of your debt is wiped away, you don't owe anybody anything. Then there's Chapter 13, and this depends on how much money you make. So Chapter 13 is a restructuring of debt. So we're not going to write, the court is not going to allow you to write off all your debt and you don't owe anybody anything. They're going to restructure your debt. So the way that works is federally, it works that if you make $65,000 or more a year, you cannot file for Chapter 7. You have to file Chapter 13, which means you are going to be liable for paying something back to everybody you owe. Typically, though, usually they'll let you get rid of about 85 to 90% of your debt. So then you have 10% of the debt, the total debt left over, and you have to pay all of those debtors. or all of those creditors. And normally you don't pay them individually. You'll pay a trustee, and that trustee will divvy out the money. Okay. So those are the two types of bankruptcies that you'll see, personal bankruptcies from patients. Okay. So what's the best way to do these things to try to collect money? Number one, remember to be tactful. Remember that financial issues for most people can be embarrassing. We have to have empathy with those patients. We should try to understand where they're coming from and what they can or can't do. But we also want to make sure that they follow through with any agreements that they make. So getting these things in writing, explaining these things appropriately, doing appropriate follow-up is typically the best way to get patients to be compliant with whatever they've agreed to do. All right. So that's it for chapter 13. That gives you a little bit of extra background on that one. So I have enjoyed Monday Morning Messages with you guys, and I look forward to seeing you next week for another Monday Morning Message on chapter 14.